Good afternoon, guys. My name is Dr. Hamza, and I am one of your mentor for MRCPCH FOP and TOS. So now I warmly welcome all of you. So thank you for coming. So today we will discuss October 2023 recall paper. So if you have any queries, you can ask me in the end, right? Okay. So first of all, we will discuss about the paper. Just first of all, we will discuss about the questions, and then I will ask you guys about the answers, right? And then we will go ahead. We will make this session as an interactive session as well, right? So, are you guys with me?
Yes, sir.
Yes.
Okay. Shall we start now? Okay, thank you. Thank you for. So first question of October 2023 is EMQ, but nowadays there is no EMQs. First of all, but now this question could come as a best of 5 question. Okay, PO. Yeah, okay. So now coming to the question 1, right? 14 years old girl coming with bending headache, not associated with vomiting from past 3 months, taking paracetamol 6 times daily, ibuprofen 400 mg 6 hours for 3 weeks, right? So what do you think? What could be the right answer here? I'm just asking you. Then I will explain it to you guys. What do you think? What it is, and what is the right choice? What do you think?
No treatment.
Hmm?
No treatment.
Okay,
No
why you?
Medication overuse headache.
Mhm,
Drug-induced headache. When someone taking a lot of drug for headache,
mhm.
it also cause and also induce the headache. So you should discontinue the drug.
Mm-hmm. Yeah, absolutely right. What's your name? I don't know because I can't see. What's your name? Who's telling this?
What?
What is your name? Who is telling this?
Burhanuddin, I'm your paid group student. Faizan Mustafa.
Oh yeah. Very good, Faizan Mustafa. Okay. Very excellent, brother. So you are absolutely right, Faizan. Okay. So basically, it is a bending headache. You can call as a tension headache. Now what is basically you call it as a case of drug-induced headache. Whenever if you take a drug for chronic, like for long time, in per week more than 2 times, right? Like in a week, if you are taking 2 times for very long and you are having headache, right, for more than 15 days per month. Okay, like you if you are having headache more than 15 months for 15 days per month, 1 point. And second, if you are taking this NSAID more than 2 times per week. Okay, so it is a headache that is basically due to drug. Are you getting me? So in here, as he is taking paracetamol 6 times daily, oh my god, too much. Ibuprofen 6 hourly, mean QID, for 3 weeks due to his uh, tension headache, right? Bending headache. But it's not improving. It's mean that it is a headache due to chronic use of NSAID, which is called as drug-induced headache, as Dr. Faizan Mujtaba has said, right? So here, the best treatment would be no treatment. Are you getting the point? So if this question come like that, you just answer it simply that no drug treatment is required as it is due to NSAID-induced headache. Okay? Do you have any queries here? You can ask me. Shall we move ahead?
Yes.
Okay. So boy coming in a road traffic accident, head hematoma, fracture femur, head need to do CT brain, but first femur brace, GCS 12/15, CRT4, HRT 150. So what do you think that what would be the right answer here? Guys, what do you think?
CT scan.
Femoral nerve block. Femoral nerve block.
Femoral nerve block.
Femoral nerve block, 2% are saying, one is saying CT. There is no option of CT. Where is CT?
Femoral nerve block.
They have already done CT.
Okay.
Because it is a bone pain and it's very painful. To reduce
Look,
like regional pain, we have to reduce the regional pain.
absolutely right. Absolutely right. Actually, this whenever always remember when femur fracture is there is a blood loss. Okay. So this blood loss is so massive that it could result in shock. And you can see here the patient is going towards the shock. Look at his heart rate, look at his CRT. Because CRT is more than 2, its patient is going into dehydration, going into the shock. GCS is also dropping, right? So here, the best treatment would be now in the question you see, because now they are CT, but first femur brace, right? You're getting the point because they are femur brace because they have to stabilize hemodynamic, okay, hemostasis actually. That's why they have to put femur brace, but femur brace obviously it is a painful procedure, so it exacerbate the symptoms, so we have to control the pain, right? So best would be to give femoral nerve block along with doing femur brace or femur repair. Getting the point? So if you are talking about diclofenac, ibuprofen, paracetamol, they are oral antibiotic, right? Oral these painkillers, right? So these oral painkillers would take time, to affect. So better is to, if you are performing any regional repair, you should give something that is close to it. Like if you are performing femur repair, you can give a regional anesthesia with femoral nerve block, right? So it would be very easy, and it would also reveal the pain, and it would alleviate the symptoms. Okay. Now you guys would be confused with option E, anti-nox. Have you heard anybody heard about anti-nox? What it is? Anyone here? Anti-nox. What is anti-nox? Anyone? If you guys don't hear, I can tell. Okay. So
Anesthetic
gas, mixture of nitric acid and oxygen.
What? I can't hear you. What you're saying? Actually,
Anesthetic agent, it is a gas.
Yeah, it is basically a gas, anti-nox. It is basically used as anxiolytic. Mean if, for example, somebody having a needle phobia, right? Or if someone is going for emergency procedure, dental procedure, he is getting anxiety. So anxiety induces the pain, and it will increase the pain threshold, and moreover, it will exacerbate the symptoms. So at that time, we can give anti-nox, okay, as anxiolytic. So that's it. So here the best answer is femoral nerve block. Anybody having any question here? You can ask. If no question, we can move ahead. Okay. We have to cover whole paper. Yeah.
Hello.
Yeah, you can ask. Yeah.
Please explain third question again.
Which one?
Not,
Third?
Third one.
Third,
Child
we will
coming with
read.
burning first.
Yeah, I am reading now. We have done only first 2. Okay. Child coming with burn in the chest, right? Upper limb by fresh hot coffee, tap water over burn, cloths remove, cool peripheral examination, and coming screaming now. What you will do? Tell me, guys. Very easy answer here. Tell me.
Intranasal diamorphine.
Intranasal diamorphine.
Yes,
Okay.
actually.
Why do you think so? Why intranasal diamorphine in case of burn with a child?
Because
Why?
all the limbs are involved, we have no site for IV lines, and there is no role of the oral antipyretics. That's why.
And usually in the child, you are burning is a severe pain.
Yes.
Absolutely right. Actually,
Pain
you read
because
in
of the
third year
fast
pharmacology, You read in third year pharmacology that the best route that passes the first pass effect, and that basically is more like in short duration, it will elevate the pain, is intranasal, or you can say mucosal, submucosal. Getting the point? So
Yes.
better is to intranasal diamorphine, so it would elevate the pain, because burn pain is very severe, right? It is not like that. And if we are doing IV cannula, it would take times in child, and it will take times. Moreover, there is bullae over there, So if we rupture them, there is a risk of infection. So if one question come, you always enter nasal diamorphine because it is easy route, effective, and short in duration.
Okay,
Getting the
thank
point?
you. Thank you.
Yeah. That's okay. So this is the answer. No treatment, femoral nerve block, intranasal diamorphine. Okay, guys. Next question. Baby aged 4 months, 28-week preterm, was ventilated for 3 weeks, oxygen dependent, 4 month, recurrent croup attacks. Last one admitted and intubated. Investigation needed. First of all, tell me what is your differentials here. Then we move ahead. Yeah, please, guys, just interact. If someone speaks wrong, it's okay. No problem. No one is here. Yeah, just speak. I'm listening. What do you think? What is the diagnosis here? Why they are?
Sir,
Chronic lung disease.
sir, it can be subglottic stenosis.
Excellent, brother. Excellent. And other?
Very
This is
good.
because of prolonged intubation, which causes subglottic stenosis, and now this happened.
What do you think about bronchopulmonary dysplasia? Could
Yes.
it be?
Yes, yes, it can be.
Yes, it could
Yeah.
be.
Yes.
Okay. So do differential we can put here, right? So what would be the investigation of choice in this, guys?
There is laryngeal bronchoscopy.
Excellent. Excellent. So basically, we will do laryngeotracheo. Why broncho? Because laryngeotracheo subglottic stenosis, right? Bronchoscope to look for the lungs. Because in bronchopulmonary dysplasia, lungs walls are totally been replaced. Okay. So best is to give laryngeotracheo bronchoscope. Excellent, guys. This question was difficult, but you have done a very good job, right? What other question? What other options came in your mind when you were doing option A? I want to know, because some would say chest X-rays. Yeah. Yeah. That's the best answer. Anyone having question? Anyone having any question here in question 1? You can ask me. Yeah. Shall we move? Okay. Child 14-year-old.
What are the diagnoses you made in question 1?
Question 1, yeah, there are 2. One is subglottic stenosis, other could be bronchopulmonary dysplasia, right? Okay. Okay, you got it?
Oh, okay, thank you.
Okay. Child 14-year-old on inhaled fluticasone, mean steroid. 750 MIC coming with fever, cough, other children not as severely affected. He was lethargic, pale after one attack of vomiting. There was dropping in the weight. Investigation needed. Tell me your diagnosis, guys.
Short synapse test, Addison disease.
Addison disease.
Excellent. Thumbs up. Why?
Because he is on fluticasone and now is having acute current illness.
Yeah.
Illness.
Absolutely. Because now double dose is required, right?
Yes.
Whenever there is infection, you have to increase the dose to double, right? Now, what this is the counseling we have to do to the parents, that whenever there is basically infection, you have to increase the dose by telling to the doctor, coming to the GP clinic, right? So here, now, what are the points towards Addison, right? Lethargic, right? Vomiting, dropping in weight.
Okay.
These are the indicators with superadded infection and taking fluticasone. There could be drop in the BP, right? There could be bronze skin pigmentation. Sometimes pigmentation is also there. These all things could be there, right? So better is to do short synectin test. That is basically used as an investigation in this case. Okay, guys.
Okay.
Okay. Girl with cough fever received amoxicillin, no improvement. On examination, stolid dullness. Now you know what it is.
Pleural effusion.
Ultrasound
Ultrasound
chest
chest
because if
because
he
it is a pleural
has
effusion.
pneumonia or
Definitely.
something,
What did you do?
ultrasound chest.
Absolutely correct.
Ultrasound test.
Excellent. Excellent. You are great. AED. A. Yeah. Other is which one? A, B, C, D, E, yeah, and D, and D. Actually, I made myself this key, right? Okay. Next is EMQ3. 6 year. This is very interesting question. Question one. Very interesting. I want your input, guys. 6 year mother, child 6 years mother heard abnormal voice in child room. She found the child has abnormal twisting movement in one side of the face with abnormal eye movements, drooling saliva, sweating the night during sleep and feeling tired, and he cannot speak with mother attack repeated 2 times before. What do you think, guys? Tell me.
Lentic epilepsy. It's benign childhood epilepsy.
Why not complex partial? No, answer me.
Because
Hmm?
it's more during sleep. I have read somewhere that rolantic
Yeah.
epilepsy
One
increase
point
during
is very
night.
yeah. Excellent. One point is during sleep or during a that is towards benign child epilepsy. Other points? Have you heard about automatism?
Automatism, yes. Sir.
These are basically purposeless repetitive movements like lips smacking, nonsensical speech, wandering in the room, impaired. Another points are impaired to the surroundings. These are there. But here he is night during sleep and he cannot speak the mother, right? And he is having so when I was reading now, I just memorized rolandic epilepsy with stroke like symptoms. How in stroke you will get aphasia, right? You will get one side of the body involvement, right? So you can see here there is a twisting movement on the one side of the face and abnormal eye movements. Point one. Second is there is also drooling of saliva that could be seen in stroke, and there is aphasia. You cannot speak with mother. Very easy to remember with rolandic epilepsy. Getting my point? But three things I told that is similar to stroke. One is one side of the body or one side of the face, like Bell's palsy. Other is aphasia and the drooling. You can see same here. And what EEG changes are seen? That would you will give in AKP part 2. Centrotemporal spike.
Oh, sorry. Central temporal spike.
That
Sorry.
is hips arrhythmia is infantile spasm.
Yes, it's the
Yeah, the West syndrome. Yeah. That is centrotemporal spike. In the center, you will get spikes. Otherwise, it would be normal activity. Okay, so during sleep, during wake, similar to stroke, twitching movement on the face, mean that is similar. Abnormal movement, that is benign childhood epilepsy. So, what is the treatment of this? What do you think?
No treatment required.
Yeah,
Think.
really,
No treatment is required for rolantic epilepsy.
absolutely. But if it is interfering with the day-to-day activity and disturbing the parents at that time, what you will do? But which anti-epileptic you will give? If it is disturbing, if parents need it, they are just saying no, I will need for few time because it usually goes away when the child is in teenage. Then you will get carbamazepine. Okay. Because I read in part 2 when I was preparing, there was one thing that I read. Okay, scenario with the toddler got pale and loss of consciousness after second after he hit by a head by a table with muscle twitching. Tell what it is.
It is reflex anoxic seizure.
Yeah. Why?
One thing is loss of consciousness only for second.
More?
There could be a
And
history of
because
hurt or fall or something.
Yeah.
it is child showing tantrums.
Mm-hmm. Yeah. So actually, he got pale after he hit.
And during the fits, fell during the fits.
Absolutely. Like he got pale after he hit. Na? You have to read the statement, right? Anigar, muscle twitching, and you have to remember it is seen in 1 to 4 year of age. 1 to 4, just
Yes.
write somewhere. Okay, mainly it is seen 1 to 4 year according to the guidelines, pediatric guidelines. If you open, and one more very interesting thing is that its signs and symptoms are very similar to epilepsy. You can see there would be urinary incontinence, there would be abnormal body movements, right? But here you will get the history of temper tantrum or pain, anything. That is important. This is how you differentiate between the two. Okay.
Okay.
Any question here?
Sir, there is no history of any.
Excuse me, the voice was speaking. The answer to the question is
Question B.
yes. Question B.
Reflex anoxic seizure.
Reflex and oxygen. Okay.
Yeah. Okay, what you were asking, doctor?
Sir,
Yeah.
sir, I'm just asking that there is no history of any irritating factor that irritate the child and he start showing tantrum. He has having just, then how could it be anoxic seizures?
Look here. Loss of consciousness after he hit his head with a table. So temper tantrum could be there.
Okay.
He like
Got
hit
it,
by a
sir.
head.
Got it.
Yeah.
I
That's
think he hit after having fit. Sorry.
no. Scenario about toddler got pale, loss of consciousness after he hit by mean after hitting he lost his consciousness, huh? Mean preceding risk factor was hit by a head.
Okay.
Okay, it's not like that, loss of consciousness and then hit by. After hit, look, second after hit. Okay, if it is before, then you can say epilepsy. So you have to read the statement very carefully in the exam, because nowadays they are just okay. Next is scenario about feverish child 39 with abnormal body movements that stop when you touch him. What it is?
It is rigor, sir, because
Yeah.
it stops when we hold the hand.
And what is jitteriness?
Jitteriness is,
I think so.
They are
It is without
they
temperature.
are one and the same thing, sir.
yes, it is without temperature. Yes.
Yeah. Okay. Next question. 7-week increasing. Okay, we will read first of all. Okay, 7-week increasing non-bilious vomiting, non-bilious. Okay, lethargy, fever 38.5, not well, not feeding well. What do you think, guys? Just read.
UTI.
Okay, other guys.
Not well, not feeling. Yes.
Yeah.
UTI.
Great. Why UTI? Can you
Ma'am,
explain?
fever also. Fever not
Malnutrition.
well.
Okay. Excellent. Always remember that less than 3.
UTI.
Yeah, UTI. Less than 3 months, there is a non-specific sign and symptoms. Even of meningitis, you will get non-specific symptoms. Even you could get hypothermia as well in case of hypothermia, right? So less than 3, you have to consider UTI. And here he is not feeding well, right? His temperature, normal temperature is 36.5 to 37.5. Just write somewhere 36.5 to 37.5. Here you can see that his temperature is 38.5. Mean low grade temperature is there with not feeding. So here only UTI is the right answer. Okay. Just write 36.5 to 37.5. Just write somewhere. It will help you guys. 7-week well being. Yeah.
37.5 is a normal temperature.
How much?
36.5 to 37.5.
Yeah.
Okay, thank you.
Okay. 7-week well baby, 48-hour intermittent bilious vomiting, baby tachycardia, capillary refill, 4 second. I think so. Typing mistake is there. 4 second. Okay, 3 question is there. Okay, last question. Okay, 7-week well baby, 48-hour intermittent bilious vomiting is there. Tachycardia, capillary refill, 4. What do you think, guys?
Malrotation.
Malrotation.
Why?
Bilious vomiting.
Malrotation.
And signs of shock.
And there is intermittent bilious vomiting, no?
Always remember, excellent guys. You are very competent. All who is speaking. I don't know who is not speaking. There would be also. Okay. So basically, malrotation is usually seen in first 3 days of life. 1, 2, 3. Right.
Okay.
And the other thing is that why tachycardia capillary? Because it could cause signs of shock. It could cause peritonitis. There could be tenderness. Okay. So tenderness could be there due to peritonitis. There could be signs of shock. So it is malrotation. Just remember it. Okay. So signs of shock could be there. Just a second, I am telling you. Just a second. Here it is. You can just see here. Can you see the screen?
Yes.
Uncommon but important to diagnose, usually first 3 days of life with intestinal obstruction, may present with any age, volvulus causing obstruction in ischemic bowel. Clinical feature are bilious vomiting, abdominal pain, tenderness, peritonitis, ischemic bowel. So urgent upper GIT contrast study is indicated, right? I'll send this in the group, okay, later on. Okay. The next is a question: a 7-week-old baby with a non-bilious vomiting. Okay, with the non-bilious vomiting, also hungry. What is?
Pyloric stenosis.
Yeah, it's easy because hungry.
Yes.
Bilious vomiting, 2 to 8 weeks. What is the time interval of pyloric stenosis? Just write it: 2 to 8 weeks.
Yes.
And other than that, what is electrolyte imbalance? Anybody can tell?
Hypochloremic, metabolic.
Excellent.
Metabolic acidosis because of acid loss.
Yeah, excellent. Excellent, Vedant. And guys, other.
So hyponatremia also may be present. Hyponatremia may also present.
So hyponatremia could also be there because acid is getting lost. But commonly we usually see hypochloremic metabolic alkalosis. Okay. Okay. Next is baby with molluscous condition teased at school. What you will do? Whether you will reinsure or you will give silver nitrate cauterization. First of all, tell me.
Silver nitrate cauterization.
Silver
Why?
nitrate, because he's been teased by in the school.
Absolutely correct. If it was not teased at school, then we will give simple insurance because usually resolve on its own. It is caused by pox virus, right? That's it. So teasing in school is indication of silver nitrate cauterization. Simple is that. Excellent work, guys. Okay, hemangioma in the eye difficult to open. What you will do? I give you 2 options. Just listen.
Propranolol.
One is refer to ophthalmology. Other
Can
is
I question, please, doctor?
yeah.
Propranolol. We can give
When we
propranolol.
use cryotherapy
Beta
in
blockers.
treatment of molluscum contagiosa,
Can you speak again, please? Sorry, I can't understand.
when I can use cryotherapy in treatment of molluscum contagiosa, because I see a lot of answer. The answer is cryotherapy. Sometimes the answer is silver nitrate.
Excellent question. So if it is on the face, don't try to use cryotherapy because cryotherapy is basically freezing it, and it will basically leave the burning marks. Okay. Other than that, if it is not on the face or it is all on the body, then you can use cryotherapy. Got it?
Okay, thank you.
Yeah. Okay. So now I have 2 options here. Hemangioma in the eye difficult to open. Whether you will refer to ophthalmology or you will give propranolol.
Propranolol.
No. Always refer the patient to ophthalmology because in the UK they have eye difficulty. Whenever there is difficulty in opening eye, you have to refer patient to ophthalmology. This was the question that I read when I was preparing. Okay. So second best is propanolol. Okay. So just remember, whenever specialty is required, you have to refer. Okay. So if here two options were there, you have to pick the ophthalmology. Are you with me, guys?
Yes, yes.
Okay. Clear? Eczema, skin dry. His brother has eczema, dryness in the back. So first line of treatment is, in this case,
Emollient.
absolutely correct. Excellent. Excellent. Second line?
Second line is topical steroid. And third line is calcium urine inhibitors.
Yeah, tacrolimus. Tacrolimus like that is one is tacrolimus. Yeah, you're right. Absolutely correct. What is the most potent corticosteroid?
Clobestal.
Clobetazole.
Zone or sol?
Zol.
Sol.
Clobetazole.
Sol. You can remember from foot sol. Most. Okay. Okay, this is a difficult question. First of all, we will read question 3. Okay. 5-year had a skin rash 2 weeks ago. Then developed puffy eyes, urine protein 3, and blood 2. What do you think, guys?
It may be a case of chronic kidney disease.
No, question 3.
Question 3?
Yeah.
Question 3 is acute eye and also hematuria.
Yeah.
After 2 weeks, it may be acute glomerulitis. Yes, it is AGN, case of AGN.
Yeah. Acute post-septic glomerulonephritis. Why? Because two things you have to know. Yeah. One is pharyngitis that is seen in 2 weeks, and other is impetigo.
Yes, sir. Sorry for one option that in acute glomerulitis, I saw in some book that there is maybe 2+ proteinuria.
Yeah, there could be because it is nephritic. In nephrotic, you will get 3+, then you can diagnose.
Yes.
Okay, like 300 mg per deciliter. That is 3+. 1+ is 30 mg per deciliter. 2+ is 100 mg per deciliter. 3+ is 300 mg per deciliter. So 3+ is at least required if you want to diagnose a case of nephrotic syndrome. And albumin should be less than 2.5 gram or 25, less than 25. Okay. So this is the answer. Okay. So now question 1. 15-year females, small, didn't start puberty. Means some chronic. Okay. Urine blood 2, protein 2, creatinine very high, 595. Sodium low, potassium. Those guys tell me.
Polycystic kidney disease.
Chronic kidney disease.
No, chronic kidney disease.
Why polycystic? Why? Can you tell me, doctor, your name? What is your name?
Yeah, my name is Dr. Aparna.
Okay, Dr. Aparna, very good. You have interacted. Excellent. So why you are saying polycystic kidney disease? Can you please explain?
Sir, it is Turner syndrome, and there is like horseshoe kidney, polycystic kidney is common in Turner disease, and there is a obstructive nephropathy, so it causes chronic kidney disease. Eventually, it causes chronic kidney disease, but
But in Turner, there may be also pressure difference in the hypertension and some other issues.
Yeah, Dr. Aparna, actually, Dr. Fizana said right. What actually happened that if it was a case of polycystic kidney disease, get hypertension, that is very important. You can get liver in aneurysm, brain berry aneurysm, right? And you can get another, could be urine blood or protein blood. And never ever say Turner syndrome, and never until you didn't go into the diagnosis. I just want to tell you that in chronic illness you can get short stature and you cannot start puberty. It doesn't mean that if patient is having a
CKD can also have
CKD
small stature.
What
It's
CKD
not
has?
necessary that CKD also have short stature. It is not necessary that Turner is having short stature only. CKD
Yeah,
can also
definitely.
causes
Yeah.
faltering of growth. It is a case of CKD with faltered growth and this type of biochemical picture.
Absolutely, you're right. CKD is basically what here the answer, because look at the creatinine, and in polycystic kidney disease they will give you typical like father history, like family history, because it is autosomal dominant. They will give high blood pressure. They could give a history of headache. They could give history of abnormal liver enzyme. In addition to, they will give a microscopic hematuria, a renal flank pan. Getting the point, na?
Okay. So yeah.
Yeah, they will
Understood.
give
Yeah.
multiple things. Okay, so here the answer
Yeah.
is C. So that is basically the right answer here. Okay,
Okay.
chronic kidney disease. So 14 months vomiting, have fever, creatinine 55, BP is 90/60. What is your diagnosis? Fever. What do you
UTI.
think?
UTI.
Yeah, definitely. Actually, na here guys, this is a recall. That's why they haven't given a complete statement. But in the exam, there are very long questions. You will able to really. Don't worry. Okay. So don't just worry that they have given creatinine and BPs and you are just worrying. Okay, don't worry, guys. Okay.
Yes, sitting in fever is the sign of UTI.
Yeah. Is a fever is a fan of UTI in later age.
Yes.
Okay. Now coming to BCQ. Down child teaching complaints of sleeping at night, and the mother say he is restless sleep. History of otitis media. OSA or hypothyroidism.
USA.
OSA. Why not hypothyroidism?
Because the
It could be
child is sleeping.
maybe
Because the child.
maybe I have marked wrong. Maybe.
No. Because no. I'm saying because
Mother,
the child
mother,
has Down syndrome, and in Down syndrome, children do have OSA, and
Mm,
they sleep during class in the morning. They have
yeah.
difficulty sleeping at night.
mother
Yeah.
is
What's your
saying that
name,
he
doctor?
has
Excellent.
My
restless
name is
sleep.
Dr. Hajra.
Okay, Dr. Raja. And oh, you're Dr. Rajara. That is okay. Excellent. Okay, so basically, excellent, Dr. Rajara. You have explained very nicely. Down syndrome, adenoid hyperplasia, or could be tonsil enlargement, complaining of sleep in the class, and restless sleep, history of otitis media, obstructive sleep apnea. You have to do sleep study, that is polysomnography. Simple question. Don't need to worry. Okay.
What is in the sleep study?
Polysomnography.
Okay.
You have to check for oxygen, you have to check for BP, you have to check for pulse. These are all things you have to look. Okay, that's why we're able to know. Next question is, child with hyperactive impulsive abnormal behavior diagnosed with ADHD on methylphenidate, mother complaining he don't play with his sister, delay in preparation of for school, difficulty in handwriting with additional problem. What do you think, guys?
Hmm.
It has
What do you
Dyspraxia.
yeah, difficulty writing, dyspraxia.
Okay. Why not side effect of methylphenidate? Why dyspraxia you are saying?
Because maybe difficulty in handwriting.
Look, I will tell you. The side effect of methylphenidate is also dyspraxia. You know?
Okay. No.
And important thing is that the side effect methylphenidate is dyspraxia. What are the other side effects? Weight loss, anorexia, increased BP, growth problem, dyspraxia. Now they given side effect of methylphenidate as well dyspraxia. They are very clever. Okay. So that's why you have to opt side effect of what is ASD? What is a spectrum disorder? Here, the child will remain isolated and he will have a routine, tidy, right? Schedule. Like he will play with toys and he would be very good at maths, right? That is an autistic spectrum disorder. That is Asperger's syndrome. Also, you can see that loud noise, you're not responding, right? So here, B is the right answer. Are you getting the point, doctors?
Sir,
Are you here?
If this child
Yes,
is
yes.
not on methylphenidate, then the option is dyspraxia. But
Definitely.
there
Definitely.
is the trigger or a risk factor, that is the
Yeah.
drug. So the
Because
drug
look
is
now,
the main cause.
diagnosed area on methylphenidate. You can clearly see. Now you're clear about the side effect of methylphenidate.
So, sir, what is the answer? What is the answer to this question? Is it side effect or is it dyspraxia?
Side effect. Yeah. Okay. Because look now, he is on methylphenidate. If he was not on methylphenidate, then we couldn't see that. Yeah. Okay. Dyspraxia. As doctor told, I don't know what that doctor name, but he told dyspraxia. As he is on methylphenidate. Okay. What is basically role of methylphenidate? Mechanism of action.
It increases the reuptake of noradrenaline and dopamine.
Basically, it increases dopamine and norepinephrine, both.
Yes, sir.
Next is atomoxetine, that and amphetamine, I guess. Yeah, we can.
Tamoxifen also same mechanism.
Yeah, excellent. Very interesting question. 2-year, very interesting. Now you'll get puzzled. 2-year-old alert, child vomiting, diarrhea, 2 days, blood sugar 2.1. Options are IV dextrose 10%, IM oral fluid containing carbohydrates, IV dextrose 5%.
Oral fluid is right answer because child is alert.
Excellent. Other point?
But Dr. Hamza, there is a question that child is vomiting now. If child is vomiting, then how we can give oral?
Yeah, that's very good question. That child is vomiting, but look, he is vomiting. He is having a diarrhea, but you can like what we.
Sir,
Yeah.
in vomiting, we do prefer giving oral, but we have to give like sip. Like we ask the mother to give one sip and then stop for 10 to 15
Yeah.
minutes. Then again give one sip and stop. Like this, we can give oral
We can.
fluid.
That's important. Other, in normal, that's very good point. Another is normal is that whenever a normal child is there, we can give a syrup of antiemetic. Even child is vomiting, we encourage in our routine OPDs. You can say that just take this antiemetic, as your child is not that much dehydrated. He is just taking orally, no sign of dehydration. Just give this antiemetic 30 minutes before giving anything. You're getting my point? So he can take.
Okay.
Getting like in OPD, we normally do not these things. Like we say that there is no sign of dehydration. Yeah, at that point when there is a severe dehydration or some dehydration is there, at that time, even if you read some dehydration, mild dehydration, we encourage, even child is vomiting, we encourage to take ORS after each stool. Then why we are giving ORS? We need to give ringer lactate. But your question was very good. I really appreciate. So now one thing more now here. Not only alert, his blood sugar is more than 2.
Okay.
Getting the point? His blood sugar is more.
Yes.
And now, if his blood sugar was less than 2, at that time, we could consider. And if he's unconscious at that point. So now here his blood sugar is more than 2 or 2 or more than 2. At that point, we give solids according to the guidelines. If he cannot take the solid, then we can give glucogel, right? Glucogel. Okay. Solid fluid or glucogel. Okay. However, if GCS is dropping less than 8, right, or his blood sugar is very low, okay, at that point we will maintain his IV line. We will give bolus. Let me tell you just a second, because here you will guys not understand. Can you see?
Yes.
Assess blood sugar less than 2.6 millimole per liter. Now we will have to look whether GCS is less than 8 or more than 8. If GCS is less than 8, then we will maintain his IV line. Okay. We will send his blood for hypoglycemia investigation, and we will look for other. And we will maintain maintain his IV line, give 10% dextrose, 2 ml per kg bolus, followed by infusion of 10% glucose with sodium chloride at 100% maintenance fluid. Are you with me?
Yes,
However,
sir.
however, if GCS is not less than 8, mean more than 8, as in this case, then we will give solid fluid, feed solids. If not tolerated solids, then we can give glucosate, flat, or glucogel. I will share this guideline in the group. Okay. Later you
Okay,
can see
sir.
more. There it is. Just for your, that's enough. Okay. Remember, guys, recalls are very important. Very, very important. If you want to pass, just do recalls. You will pass. I'm 100% sure. But do with logic, not ratifying. Okay. Okay.
Okay.
Child
Sir,
10
when will,
years. Yeah.
sorry, sir. Sir,
Yeah.
when
Yeah.
will you do the other recalls before February or not?
Yeah, I will try to arrange another session inshallah soon, but you can contact our team as well. They will guide you. Okay.
Okay, sir.
Sure. Okay. Child 10 years on 2 puff preventer, 12-hour treatment for asthma was controlled. There was new guidelines, cheaper 15%. The old guideline recommend to wean if controlled. Okay. Now they are basically asking now how you will wean off. Okay, like new drug you have to give and how you will wean off. Okay. Give 1 puff of old preventer twice daily. Use new preventer same dose. Use old preventer same dose. Stop spacer. What do you think, guys?
Don't know.
Any other guy who can tell? This is good, difficult question. Okay, I will tell. Basically, na, what we do whenever we add new drug. Okay, new drug in case of asthma as a inhaler, right? For example, he is taking salbutamol. For example, 2 puff in the morning, 2 puff in the evening. Okay, so we will just emit the 2 puff, mean the 1 puff out of 2 puff in the evening one. Okay, like 2 puff in the morning, 2 puff in the evening. So the night, in night there are 2 puffs. Okay, so 1 puff we will eliminate. After 1 month, if he is coping with it, we will also eliminate the night, the other one. Okay, so we will only give the 2 morning and we will add the new drug. You
Okay.
getting the what I'm trying to say? Mean, for example, I can explain you. For example, a person is taking NSAID, for example, Brufen, 2 tablets in the morning of 400 mg and 2 tablets of 400 mg in the evening. Okay, so now he will omit 1 tablet in the evening one for 1 month. If he is sustaining his pain, then we will, after month we will just also omit the night one, night dose, the other tablet. So we will give only 2 morning, and then we can add other painkiller as well. Just trying to
Yes.
you guys how you do. Okay, so this
Okay,
is the
Dr.
way you.
Hamza. Okay, thank you.
Yeah, just a second, I'm coming back, just a second. Okay, so next question is, child diagnosed with pyloric stenosis, GP would like to refer for surgery after giving 48-hour IV fluid electrolyte or follow. Chloride was less, potassium is still less, and sodium is normal. What is the next management? What do you think, guys? Tell me.
I think continue IV fluid till electrolytes are normal, then refer to surgery.
Okay, 1 point. Other guys?
I think same. Continue IV fluid till the electrolytes are normal, then refer
Okay,
to surgery.
I deliberately marked A wrong. You know, A is wrong.
Okay.
I wanted to test you guys.
Okay.
So very excellent. What is your name, doctor? Good. What is your name?
Dr. Kuratulay.
Okay, Dr. Kurutalan, excellent work. So continue IV fluid till electrolyte are normal, then refer to surgery. Okay, this is this is very important. Okay, you have to give IV fluid till electrolyte are normal, then refer to surgery. If this question come, you have to mark B. I think so. There is no explanation to this question.
Yes.
Okay, because definitely electrolyte imbalance would be there when you will try to do surgery and this stuff, because it could have a dreadful consequences, right?
मेरी क्लास है अम्मा देखो बहन खाला आ गई अब तो
Okay,
देखने क्या आता है
okay. 10 guys, can
ये तो मुझे क्या करनी है उससे ये वाली तो मैं लिख रही हूँ ना तो मुझे लिखना है आंखों में आंसू क्यों आ गए
guys mute your mic, please. Okay, 10-year child with blotchy rash, 4 episode in the last 4 months, accompanied with perioral swelling. The rash is itchy red, occasionally white, and lasts for 12 hours. He complains of mild asthma and facial eczema in the first year of life, and he has soya milk since 3 years of age. Mother complains of swollen eyes when exposed to pollen. What is your diagnosis? Guys, come on.
Why not? It's a hyper IgE syndrome.
Okay, why not hyper IgE?
Because he has facial eczema in early life, also cause milk protein allergy. Now he also has swollen eyes when exposed to the pollen. So
I will
it
tell.
is why not it's a hyper IgE.
Hyper IgA syndrome is job syndrome,
Yes.
right?
Yes.
In job syndrome, first of all, you will get dysmorphism, like deep set eyes,
Okay.
broad forehead, and bullious nose. I will share the picture in the group. Okay. And the other thing is that in hyper IgA, you will get super added infections, like you will get pus, right? There could be pus like by Staph aureus. Okay. There could be. But here, if you read the question, blotchy white rash, I don't think so. White blotchy rash would be there in jobs. I never read.
Yes,
Another thing,
no.
he is
There is
having
no.
stored in last 4 months. This white blotchy rash. Okay, itchiness, and last for about 12 hours. 4 months, 12 hours, associated with eczema, asthma. Okay.
Okay.
Now tell what is answer. Dr. Fazan.
Chronic idiopathic urticaria because asthma is there, pollen is there. That's why.
Excellent, doctor.
Thank you.
Dr. Fazan, you tell. Dr. Fazan is there? I think so too. He is not there. Okay. So chronic idiopathic urticaria. Why? Because in chronic idiopathic urticaria, you can see that he is having 4 episodes in the last 4 months. I mean chronic. We usually say more than 3, we say chronic. White rash, blotchy, itchy, asthma associated. Right? Erythema multiforme is associated with herpes simplex virus. Hereditary angioedema is basically a painful swelling deep inside the tissue. It is not painful. Right? Are you getting the point? So that's why the best answer is chronic idiopathic urticaria. Guys, you have any question, you can ask me at any point. Any point, I will explain all things. Don't worry, I am here. Okay.
Okay, thank you.
Okay. Male child, 13 year, weight 99.8 centile, height 75 centile, small penis, normal testes. Mother say he have normal appetite. What investigation you will do? Tell me the answer.
Diet and activity assessment.
Diet and activity assessment.
So simple obesity
Because
now.
the child is
Case of
diet
simple
and activity assessment because the child is obese and he's perfectly okay. I mean, otherwise obesity there is nothing. There is no problem, and that's why.
Excellent, excellent. And now you can see why not Prader-Willi? Why not karyotyping?
Sir, in Prader-Willi, because he has normal appetite, but in Prader-Willi the child will eat too much.
Excellent. What's your name?
Dr. Hajra.
Yeah, Dr. Hajra, you are doing excellent. That's mind that is required in the exam. Okay. His appetite is normal, right? Although he has small penis, that could be due to extra added
small
fat.
penis is because of buried penis, because every obese child could have the small penis.
Yeah, that is basically pad. Okay. Fat pad. Okay. So diet and activity is
Why
analyzed
not karyotyping? What she explains?
because appetite is normal. In Prader-Willi, after 6 months, the appetite increases. Moreover, there is short stature. His height is 75 centile. Okay.
Thank you.
Yeah. Other than there would dysmorphism, almond shaped eyes, thin upper lip. Okay.
Okay. Thank you.
Yeah, that's it. Child 5-month-old with a history of recurrent otitis media. Last time there was right tympanic membrane fluid level. Otoscope. Mother read about glue here and afraid it will affect his hearing. What to do? So basically, it is a case of recurrent otitis media with effusion, right? So what you will do, guys? Whether you will health visitor for hearing test, whether you give analgesia for 3 weeks, whether you will refer to ENT for grome insertion, whether you will reinsure or whether you will prescribe amoxicillin. What do you think, guys?
I think,
Guys.
sir, reinsurance.
Yeah, reinsurance. Reinsurance.
Case of,
Yeah, because
it is a case of otitis effusion.
Why not amoxicillin?
Why not B?
sir, I'm saying it's reassurance D because maybe it's a glue here. It can resolve spontaneously.
Yeah, very, very close answer is reinsurance as well. But the answer right is B. I will explain why. Okay. First of all, in recurrent otitis media, there is basically irritability, there is pain. It is not like that in otitis media, you will not get any kind of pain. First, okay. Second thing is that otitis media usually resolve in 4 to 6 weeks times. Okay. So in the UK, you always review. It's not like that, but due to insurance and then okay. You have to review in 4 to 6 weeks. But here they have given 3 weeks. Maybe 3 weeks is also there, but 3, 4, 5, 6 weeks is very important because otitis media with effusion needs to resolve in this interval. Getting the point now? So we have to give analgesia to reveal the pain, and then we follow up the child up to 3, 4, 5, 6 weeks. Got it? If it was not the reinsurance. But well done. Very nice. When you give group insertion, now this is the question. Anybody? Any brilliant guy or anyone?
Insertion.
When there is a discharge, when there is runny otitis media or there is pus coming out of the lens.
Bilateral discharge.
For how much time?
More than 6 months.
I will tell. You are right. You have done very good job. You are trying to say, but I will tell. One is speech delay. Okay. Second is if you are basically having bilateral otitis media with effusion for more than 3 months. Okay, bilateral otitis media with effusion for more than 3 months, or unilateral otitis media with effusion for more than 6 months. Got it? That's right. Bilateral otitis media with effusion for more than 3 months, unilateral otitis media with effusion for more than 6 months, or and speech delay. The three are points. So either one is present, you have to do a gourmet insertion by referring to ENT. Got it?
Thank you.
So what we will do in these situations? Sorry.
In this
Grommet
situation,
improvement.
simply
Grommet
you will,
Okay.
yeah, that is for gourmet insertion. Okay, so here the right answer is B. That's it. Let's move ahead. Child 2 years with speech problem. He says several words that are not understood and feels frustrated. His grandmother thinks it is due to his tongue tie. He passed needed screen. What to do? What to do here?
Audiology, because maybe he has a problem in listening. That's why he cannot speak.
Excellent. What's your name now? I will ask your name as well. This was
Hajra.
very okay. Ajra, you are very good rice reader. Okay. Okay. So refer to audiology. That is very good. Why? Because speech problem here could be due to hearing problem. Maybe conductive hearing loss. No, he has past neurological screening, right? So maybe super added infection, maybe otitis media with infection is later on. So speech delay here, and he cannot say several words because in 2 years he can say 2 word sentence or 50 plus words, right? So that's it. Okay, so next is a picture of 3 months in child protection coming from sister for routine examination. On examination, she has multiple dark colored spots in his back and buttocks. Now you will say what it is.
This is spots, Mongolian spot.
Yes, Mongolian spots.
Mongolian spot other name is congenital. So reinsurance is required. Next question is, what condition needs surgical referral? Undesirable testis for 6 weeks, umbilical hernia 9 months, hydroceles 6 months, non-rectile of foreskin 3 years, supra-umbilical hernia 12 months. What do you think? What do you think, guys? Please answer. We have to move ahead. Undescended testes are at 6 months. We have to refer, not 6 weeks. Okay.
Okay.
Umbilical hernia 4 to 5 months, not 9. 9 months. No, sorry, 4 to 5 years. Okay, umbilical hernia at 4 to 5 years. Okay, not 9 months. Hydrocele at 1 year. Okay, and supraumbilical hernia is the right answer. Okay, just write it down. Undescended testes at 6 months. Umbilical hernia at 4 to 5 years. Hydrocele at 1 year, and supraumbilical hernia at 12 months. Okay, clear?
Okay.
3-year-old boy, mother thinks he's delayed than his sister in the same age. What cognitive behavior dad assess the child? Draw with carry on, put tie under table, turn pages of book at a time, scribbling with pen. What do you think, guys? Okay, tell me. Turn pages of book at a time. What age would be?
84 years.
Sorry?
84 years. 10 pages.
84? 18? 4? I don't understand.
No, 4 years. 4 years.
Oh. Turn pages of book at a time means simultaneously is 18 months.
Okay.
And one by one is 2 years. Okay.
Okay.
Scribble is 15 to 18 months. Okay. Put toy under table. That is basically seen in 3 years. Draw with carry on. That could be 1 to 1.5. That could be 2. That is non-specific. So put toy under table is basically seen in 2 to 3 years. Okay.
And scribbling at which age?
Scribbling 15, horizontal
Okay.
scribble, circular scribble at 18 months. Okay.
Okay, thank you.
Okay. So 9-year-old girl, sparse pubic hair, breast bud. What is 10R stage? Breast bud, sparse pubic hair. What do you
So
think?
then after 2?
Breast
Two.
bud is
2.
breast bud is
At
stage
the
1, stage 2, stage 3,
stage
Stage
2.
2.
Okay. 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 Stage 2. Excellent. And sparse pubic hair.
It is also at the stage 2.
Excellent. I will let me share it. I have a picture. I have to put my phone on charger. Okay. Just a sec. B1 is prepubertal. Okay. B2 is breast bud. Just remember breast bud. B2, a key stage of female puberty as it signifies the onset of puberty. Stage 3 is juvenile smooth contour. You know about this? There is a line below the breast. Stage 4 is elevation of areola and papilla. Stage 5, that is final, is there would be a regression in areola. So papilla would be prominent. Okay. I will share this in the group. This is very important. Even in clinical examination, it is important. Even in part 2, it is important. Even in part 1, it is important. Okay. PH1 is prepubertal. PH2 is sparse. Look, sparse mean little. Pigmented.
Okay.
Long, straight, mainly long along the base of the penis or along the labia. Third is basically, you can know now, it will increase in thickness. Like it will get darker, it will get coarser, it will get clear. Just remember CCD in PH3, CCD.
Okay.
Coarser, clear, darker, CCD. In stage 4, it would be hello.
Yes,
Hello.
we are here.
Sorry. My net went off. Sorry. Where were we? Okay. Child diagnosis with meningococcemia. What prophylactic antibiotic to his 1 month sister? What do they think, guys? Rifampicin or ciprofloxacin?
Ciprofloxacin.
Why not rifampicin?
Cipro. Rifampicin after if Cipro is not available.
Or if age is less than 10 years and meningitis is caused by Haemophilus influenza. Now here's meningococcemia, meaning Neisseria meningitis. So that's why here the answer is Cipro. So just write rifampicin, age less than 10 years, and if meningitis is caused by Haemophilus influenza. Okay, so always write ciprofloxacin. Majority of the cases, but these two instances, if age is less with Haemophilus influenza. Okay. Okay, guys. Hello.
Yes, sir.
Okay. 2-year-old boy, mother complaining he walked late at 20 month. He was delivered by forceps, added normal delivery, Apgar score 8 at 5 minutes, knows 15 words, but he cannot say 2 word sentence. Make only 3 cube tower, tiptoe walking, normal tone of lower limbs. What is your diagnosis, guys? Tell me.
Tuition muscular, because he start walking late, and tiptoe walking, and not say word to word. Maybe that's why.
Excellent. But one point you have missed.
Tone is normal.
Yeah.
Tone.
Spastic diplegia, that's why not.
No.
Because in spastic diplegia, you will get hypertonia. How you differentiate between spasticity and rigidity? That I will explain later. Okay. So normal tone of the lower limb. That differentiating it from spastic diplegia, moreover, Duchenne muscular dystrophy, the patient is basically having a language problem. He will walk delay. Okay. This is very important. In Duchenne muscular dystrophy, as Dr. Ajra has said, that there is basically a speech delay. Always remember, there is basically everything would be like tiptoe, because tiptoe could be normal. Okay, it could be normal. Yeah. The next question is Nigerian baby, a 6-week breast. Just a second. Yeah, a 6-week breastfed, 2 weeks just changed to formula feeding, then developed dark urine yellow sclera. What is appropriate investigation? What do you think, guys?
D6PD.
Okay, why 6GPD? Why? Why, guys?
Black population, dark color urine.
Just tell me one thing. Okay, very excellent. You're right. But 6GPD, if it was there, it would present first of all in first 24 hours with jaundice. Because AB incompatibility, RH incompatibility, 6GPD, they usually present in first 24 hours of life with the jaundice. Second, if you are saying 6GPD assay, always remember 6GPD assay could be false negative or false positive in case when there is hemolysis going on. So here the 6 weeks baby. Why it hasn't presented before, like in first day? My question to you. So what should be the right answer?
Direct bilirubin.
Direct bilirubin.
Excellent. Why?
The case of biliary atresia?
Yeah, excellent, excellent. That's why I want to hear that. It is basically a biliary atresia. Because biliary atresia present with after 2 weeks, okay, with jaundice, in majority of the cases with pale stool and dark urine, okay, and other thing is that he is not gaining weight. So you have to do direct bilirubin or conjugate bilirubin to detect. Brother, you have got it? What was your name? Why not 6GPD? Hello?
Yes, Dr.
Have you-
Hamza, we are here. Yes, yes.
Okay. No, that he asked no question. That's why I'm telling that where he is. I want to explain. Okay. Scenario of child 5 months, second attack of lower UTI. Culture show E. coli responded to trimethoprim with 48 hours of treatment. What investigation according to the NS guidelines? First of all, tell me it is simple UTI, atypical UTI, or recurrent UTI?
It's a recurrent UTI because there is
Why?
E. coli. Other than E. coli, it is atypical, no?
No.
Okay.
E. coli is
Okay, got it.
E. coli is in typical, not in atypical.
Yes, other than E. coli is atypical, no?
Absolutely. And if it respond within 48 hours. Let me show
Okay.
guys. Just a bit. I cannot
So,
move ahead without
difficult?
cannot move ahead without explanation. Okay. Look, simple UTI respond within 48 hours. Can you see?
Okay.
Atypical UTI, seriously ill child, poor urine flow, abdominal mass, rise creatinine, septicemia, and fail to respond to treatment within 48 hours, infection with organism other than E. coli. And what is recurrent UTI? If patient is having 2 or more than 2 episodes of UTI, means upper UTI, pyelonephritis. Or if patient is having 3 or more than 3 lower UTI, means cystitis. Or if patient is having 1 episode of UTI, means upper pyelonephritis, or 1 episode of lower UTI. Okay. Now coming to the question. Just take the screenshot of this. Okay. I will tell you. Now, what investigation you will do according to NICE guidelines? Anybody can tell? Less than 6 months with typical UTI, what you will do?
We will do ultrasound within the 6 weeks.
Yes, exactly. Always remember, in case of simple UTI, if age if we do only one investigation, if age is less than 6 months, that is ultrasound. Other than, we don't do anything in simple UTI. For example, if same question come and age is more than 6 months, we will do nothing.
Okay.
Okay. Now here age is less than 6 months, 6 months less than 6 months. That's why we will do ultrasound 6 weeks. Let me tell you. Just see here. Simple UTI. Age 0 to 6, simple UTI, ultrasound during acute infection, ultrasound within 6 weeks, DMSA, MCUG. Just remember D come before M. So that's what DMSA before MCUG. So you can simply say that only in 0 to 6 months, you can see that ultrasound within 6 weeks. Other than you said there is nothing. Okay. You have to memorize this table by hook or by crook. This is Ratta 5 table. I memorized it 1000 times, Then I remember. So you have to memorize this by own. There is no mnemonic for this. Really sorry to that. Okay. What to do? When to refer to hospital? Delay skin turgor, dry mouth, excessive drinking, or temperature 40? What do you think, guys?
Temperature 40.
Which is the red flag?
Delayed skin turgor. Dehydration.
Okay. Yeah, exactly. For example, I give you one scenario. Okay, for you guys, for your brain booster. If 2 months child come to you, mean less than 3 months child come to you with a temperature of 38, what you will do? Refer or not?
Definitely
Refer.
Refer, yes.
Yeah, you will refer, because less than 3 months with a temperature 38 and above, you have to refer. You have to refer if there is a delay skin turgor. This is a red flag given in the guidelines. Let me show you. Look at the high risk. First of all, if the child is pale, motile ashen blue, that is red flag, referral flag. We have to refer. If patient look ill to a doctor, if patient has no response to social cues, means GCS is very low, he is unarousable, or he will stay not aroused when he waked up, mean low GCS. Weak or high pitched or continuous cry. You know, one patient in our hospital, they was having continuous cry. So that's why they were red flag. We investigated that child. So red flag. Grunting and nasal flaring. Tachypnea, mean respiratory more than 60. Normal respiratory rate is 30 to 59. Chest wall recessation. Reduced skin turgor. Look, question come from guideline. Temperature 38 or more than 38, less than 3 months. Non-blanchable rash. That is meningococcemia, bulging fontanelle, meningitis, neck stiffness, meningitis, status epilepticus, focal seizure, focal neurological sign, and bilious vomiting. I'll share this in group. You have to memorize by group. Okay. Okay, next question is, now you guys will tell the answer of this. Okay, 7-year-old complains with easy bruising, clumsy walking. The child doesn't want to participate in the sport. He presented with bruising over the knees. He didn't remember any trauma, and by examining, there is multiple bruises over and below his knees. History of delay walking, and father also had a history of delay walking. What is your diagnosis, guys? Tell me. What do you think, guys?
Autosomal dominant.
Yeah. Sorry. Autosomal dominant. What?
Yes, sir.
Yeah. Excellent. So what would be the answer? What do you think? Autosomal dominant is autosomal dominant is also Marfan.
Yeah, but
Then why
in
not
Marfan,
Marfan?
sir, in Marfan, there are other features like extreme limbs are long, and chest shape of the chest is different, and
High pitched arch,
yes,
Sir,
myopia.
eye problem also.
in case
Yeah.
of Marfan syndrome, hyperextensible joints along with cardiac involvement would be
Yeah.
the most preferred thing to
Cardiac involvement.
flu. But
Yeah.
there is collagen factor
Yeah,
defect
that's the clue.
PPI, Ehlers loss is most likely the answer.
Excellent, excellent, guys. Thumbs up. And clumsy walking is also there. Okay, and connective tissue disorder, as doctor told, so that's why there was a bruising as. The next is peripheral pulse cannot be detected. Weak femoral pulse. CRT is a capillary renewal time for IV antibiotic, IV fluid antibiotic saturation is undetectable on 100% oxygen, temperature 35, mottling skin. What to do next? What do you think, guys? What it is?
It is a duct dependent lesion, and we have to open the duct. So we have to give prostaglandin. Although the age is not mentioned.
What do you think? Which duct dependent like?
PGA.
Which duct dependent?
PDA.
Hypoplastic left heart syndrome. Hypoplastic left heart syndrome, critical aortic stenosis.
PDA.
Yeah,
it could be. Excellent.
Then we have to consider
Excellent.
the
Excellent.
TGA because it present within 2 days or 48 hours.
But
Time
really
is not
TGA na? But TGA usually have no murmur in majority of the case. Okay, so excellent, guys. You're right. Left side duct dependent lesion, so we have to keep the duct open. So what is functional and structural opening of duct? Anybody? Structure, yeah. So basically, structure is basically up to 2 days, and functional is up to 2 weeks. Are you guys getting me?
No, sir.
I am saying that
You said it reverse.
The PD. Sorry. Okay. So usually that this is basically structural and functional PDA. So duct, if structural closes on day, and functional on 2 weeks. Okay. So for example, if structure it closes, we can open it functionally. Hello, guys. Can you hear me?
Yes, sir.
Yes,
Okay,
sir.
okay. Sorry for my bad connection. Okay, so what I'm saying was that PDA structurally closes as 2 to 3 days and functionally at 14 days. Okay, so what happened that we have to keep, for example, if structurally it closes, okay, at 2 day, but we can open still functionally as it is up to 2 weeks. So we can give prostaglandin E2 to keep the duct open, and so we can have this we can sustain the life of the baby. Okay, shall we move ahead?
Yes, continue.
Okay, if you don't, if sometime my net got interrupted, you can ask me again and again. Okay, I'm here. Infant 28-week admitted to NICU, prolonged ventilation, E. coli meningitis, receive antibiotic. What is a long-term complication? Head circumference 75 and head discharge 75. What is the most important long-term complication of E. coli meningitis on prolonged ventilation, on antibiotic? What do you think?
Definitely, sir. We cannot see your screen.
Oh, sorry. Just a second. Now you can see.
Yes, sir.
So deafness is the right answer because IV antibiotic like amikacin could be there, right? Moreover, E. coli meningitis is there long time. So always remember deafness is the right answer. Okay, in long term complication. Child with cystic fibrosis, bulky stool risk for healthy sister to be carrier. What do you think? 1/4, 2/4, 3/4, 2/3, or 3/4?
There's 2/3, but I don't know how to explain it. It was
I will
written in.
Look, in each pregnancy, 25% would be affected, 25%, mean 1/4. And the other 25% mean would be totally unaffected, and 50% would be carrier. Mean, for example, 4 childs are there. Okay. One would be completely affected, mean he will have a cystic fibrosis because it is autosomal recessive. And the first baby would be affected, fourth baby would be unaffected, mean he would not be a carrier as well. He would not be a carrier. Only the 2 child would be carrier. Okay, you're getting the point now? Like I would say that in autosomal recessive, if we take 4 childs, 1 child would be affected, 1 child would be totally unaffected, 2 would be carrier. Okay, so now they are asking sister to be carrier. So carrier are always 2. So now there is 2/4, 2/3, or 3/4. So we are confused between B and C, right? So 2/3 is right. Why? Because 2 are carrier out of 3, and 1 is totally affected. You're getting the point now? I mean, 1 is totally affected. He is not here. Okay, we are left with 3. So 1 would be totally unaffected. 2 would be carrier.
It's mean which one is affected? We did not count them.
Absolutely, because we don't count. He is affected. That's why we are removing him.
Okay.
We are only looking for the carrier out of 3. So 2 would be carrier out of 3. So if just remember, if autosomal recessive trait come and they are asking about the carrier, just mark 2/3. Simple. Okay. And if autosomal recessive come and they are asking about the affected, then 1/4. If same question come, they ask about what would be the risk of this child would be affected. Then what would be your answer? 1/4. Now they are asking about the carrier, so that's why 2/3. Yeah. Child complaining of recent painful complaints of defecation on examination, well circumcised redness around the anus, scratching marks. What is the causative organ? What do you think,
Sir,
guys?
it's cellulitis, group A streptococcal infection.
Excellent, excellent. Because yeah, Usman, you're absolutely right. Because the B is absolutely right. Group A streptococcal infection, right? So basically, na in threadworm, you will get these symptoms, but you will not get a painful complaint of defecation. Yeah, there could be scratching mark, but you now you look na in thread. It is basically due to threadworm. Why? Because of scratching na there is superadded cellulitis. Okay, so when there is a superadded cellulitis, in superadded cellulitis, there would be painful on defecation, there could be pus on that area, and there is a redness. If this question comes, for example, child complaining of uh, irritation and he's scratching on defecation, what is a causative organism? You say threadworm, but here there is a redness, there is a painful complaint of defecation, and scratching mark. It's mean it is a group A streptococcal infection that is super added on threadworm. So B is the right answer. Getting the points?
Yes, getting it. Thank you.
Okay. So you have to remember like that. 3-year-old child with repetitive abdominal pain, vomiting with pallor, weight on 0.4 centile, with a history of no organomegaly, normal abdominal examination with hypertension. What is your diagnosis? Now you guys will tell me. Maybe this is a distractor. Maybe it is the right answer. What do you think, guys? I want to know from you. Who will answer it rightly?
Sir, GI problem and hypertension. It's a renal dysplasia.
Absolutely correct. Why you said renal dysplasia? Hmm? Why you said renal dysplasia? You're right. Basically, he is having
because he have a feature of a chronic renal failure.
Basically, if you see now, he is basically having hypertension. That could be an essential hypertension. That could be renal artery stenosis. That could be coarctation. That could be Williams tumor. That could be renal dysplasia. But here, he is having no organomegaly. That is ruled out Williams tumor. He is having normal abdominal examination. That is ruling out coarctation as well renal artery stenosis. Coarctation is CVS, right? So it's not. So in renal artery stenosis, you will get bruit on auscultation. Williams tumor, you will get organomegaly. So A and E is out, right? But in essential hypertension, it is very rarely seen in 3 years of age, and moreover, there is a repetitive abdominal pain and there is very less weight. In essential hypertension, you will not get 0.4 centile. So we are left with renal dysplasia or coarctation. So coarctation is not a right answer. You will get femoradial delay, femoradial delay. You will get cardiovascular abnormality, and these would be there. So right answer is renal dysplasia. Okay, by exclusion. So next question is 5-week-old baby exclusive breastfed chemist seizure, ionized calcium 0.7, all are normal. What is the most common cause of hypocalcemia? What do you think, guys? In 25 question, what do you think?
A.
Why A? Why not D? Why not B, C?
A, because child is only 5 weeks. It means it is like more like a transient from mother maybe.
Right. You're right.
Yes, sir.
You, you say na all are normal. Mean they haven't. Only the problem is the calcium is no, because ionized calcium normal level is from 1 to 1.3. Okay, so from 1 to 1.3 here is 0.7. Only calcium is low, right? And all other all are normal. Mean all other labs are normal. So in hypoparathyroidism, pseudo hypoparathyroidism, you will get low calcium, high phosphate. Mean labs would not be normal. Okay, so only answer here right seem to be A. Okay. Even in maternal vitamin D, you will also affect the child and you will get abnormality, like vitamin D would be less, calcium would be less, phosphate would be high. You're getting the point, now? So that's the matter. Next question is: teenage girl complained by her teacher that she participated in school sports activity. She had an attack of palpitation tachycardia. She has a history of 2 episodes in the last 6 months. What is the investigation that helps in detecting underlying cause of palpitation? What do you think, guys?
We give a Holter.
Yeah. Very nice. Dr.
Okay.
Ajra? You Dr. Ajra? No?
Yes, sir. Yes, no, I didn't see someone else.
Okay. So absolutely correct. Okay. Patient event recorder or Holter, because this is due to event. It could be hypertrophic cardiomyopathy, it could be long QT, it could be SVT.
Yes.
Because it is happening when sports activity. So if we do 24-hour ECG, no sports activity is there, no precipitating activity factor is there, then we will not detect. So patient event recorder is there. That's why you have to read the question very carefully. Okay. Next, move ahead. 3-year-old child with cough for 2 weeks, WBC 32,000, lymphocyte 28. What is the diagnosis? Tell me, guys.
Sir, it is pertussis whenever the scenario is cough with
Absolutely.
lymphocytosis.
Absolutely.
Always about pertussis. And
Absolutely.
phase also give the
Okay, tell me, it is catarrhal phase or paroxysmal phase? It is catarrhal. Catarrhal is seen up to catarrhal, it is seen up to 2 to 3 months. After 2 to 3 months, you will get paroxysmal. So in it is 2 weeks. So I will share pertussis in the group. So it is a pertussis right answer. Excellent, guys. Next question is 14-year. 14. Kindly mute the mic. Someone is open. 14-year girl. She was doing well and she has decreased in her gymnastic activity. With deterioration of school performance, she gained weight and she has scanty period. What is your diagnosis, guys? I want to hear from you. Tell me one by one, everyone.
Sir, it's hypothyroidism.
Hypothyroidism.
Okay, 2 hypo. Okay. Hypo 3. Why?
Hypothyroidism, sir.
Okay, great. Why? Excellent, guys. Why hypo?
Sir, because PC, if it is PCO, then there is no clue of hirsutism.
School performance deterioration.
Yeah.
And
Good.
No clue of blood pressure.
Excellent. You guys are great. I don't need to explain this. Move ahead. Child become irritable in a group activity, but quiet and calm in art class. History of recurrent attack of otitis media. What is your diagnosis? Very simple question. Very smooth question, I would say.
So secretory otitis media.
Why? Because he is excellent, quiet, and calm in art class. If it was autism or ADHD, he would not be calm in art class, because whenever he is in other group activity, he can't able to hear. That's why he become irritable. Getting the point now? That's why he become irritable.
Okay.
Because he can't able to hear. That's why.
In high frequency hearing.
Yeah, high frequency hearing. You're absolutely right. 14-year-old girl with a diarrhea attack for last few months. Sometimes stool is mucosa. Weight is static for last year. He doesn't have menarche yet. Mother has vitiligo. Ask about investigation. But should be the right answer. If I was here, I would say it is celiac disease, because it is associated with the vitiligo.
It is Familial adenoid polyposis.
Yeah.
FAPCH.
Yeah. So
Because mother
basically,
is also having this history. So go for colonoscopy.
yeah, you are absolutely right. So we have to look for the colonoscopy. We have to rule any involvement in the basically. You have to look now whether what intestine is, any intestinal problem is there or
It
not.
is a case of Crohn's disease, basically.
Actually,
To rule out Crohn's disease.
actually, here could be na differentials. There could be like in Crohn disease, even in celiac, Crohn, familial polyposis. We have to
Okay.
rule out DD. So that's why we're doing colonoscopy, right? Okay, next question. This is very difficult question. Very hard question, I would say. 18-month-old with a history of upper respiratory tract infection 1 week ago. Present with concern that his chest is clear, look thin, rest of examination is clear apart with the respiration. He is tachypnic, heart rate is more lethargic, and temperature. On examination, his urine temperature is low grade, 37.8. 37.5 is normal, 37.8 is bit low temperature. Urine bag, which is in cell block, I don't know what they are trying to say. He inserted by a nurse was full. Basically, he's saying his bag was full and like he's having polyuria. What to do next? What do you think? What is the diagnosis here, guys? But what come in your mind? I wanted to know your
UTI due to faulty technique or aseptic.
Yeah, it could be UTI. What about HUS?
Yes, it might be HUS.
Very a typical case. I don't like this question. So if it is UTI or if it is HUS, you have to do CBC first of all. Then you can move ahead. Right? So probably it could be UTI, but I think, to be honest, I don't think HUS. HUS could also be DD, but I think that it is UTI. So that's why we have to do CBC first of all. Right? It could be, basically HUS. You have basically bloody diarrhea. Okay.
HUS, there is no clue of bloody diarrhea.
Yeah. Sometime now it is precipitated by infection. You don't know that it probably sometime it could be due to infection due to other infection. It doesn't mean that it could be, but in the exam they usually ask that there is basic bloody diarrhea is there. There is renal insufficiency is there, right? Okay, like urinary shutdown is there. So that's why I don't know what is a clear cut this they are trying to ask, but DD could be there. So first of all, we have to do CBC.
Baby in sepsis. That's
Could
why
be
CBC
sepsis. Could be sepsis.
Tachypneic, tachycardic, lethargic, temperature.
You're right. You're right. But why they are doing film? I want to ask you guys. CBC is okay. Absolutely. Sepsis could be there. But what are they doing film? To look for hemolysis?
Spirochetes and hemolysis.
You're right. So it could be a sepsis. Very, very hard question. So A would be right. So next is very important. You have to look very carefully. 5-year-old girl develops swollen face, skin rash after eating ice cream. No difficulty in breathing, no history of asthma, with history of asthma, eczema, other examination is normal. What is the best treatment? You will give IV adrenaline or oral antihistamine? What do you think, guys?
Oral antihistamine.
There is no
Absolutely.
difficulty in breathing, no?
Oral
So oral
Absolutely. There is no
Oral
sign of
antihistamine.
if there is low BP, GI symptoms, or like if there is a respiratory symptom, GI symptoms, or breathing problems, then you can give IM adrenaline. Otherwise, you give oral antihistamine. That's it. Child with present after B string. In B string, you will get tryptase high with rash, stridor, and pallor. Mean blood pressure is going down. Stridor, respiratory is there.
More
involvement is
than two systems involved.
Yeah, more than two system involvement is there. You
Stridor
give
shows the impending respiratory involvement, so we have to give emergency treatment.
Absolutely, I am adrenaline. Next question is 3 months with failure to breathe, breathlessness, bilateral fine basal crepitation, thrill, murmur on the left lower sternal border, oxygen saturation 95%. What is the diagnosis? What do you think, guys?
Left
Basically.
lower
Because
sternum
site
border,
of
VSD.
murmur is VSD.
Yeah. Okay, tell
All
me,
other
guys. I am
muscles
just
are
asking you. I'm just asking you. Upper right sternal edge. Murmur. Radiating to the carotid.
Aortic
coagulation of
stenosis.
Aortic stenosis.
Yeah. Upper left sternal edge. Radiating to the
Radiating to the
If radiating to the back, then pulmonary stenosis.
Excellent. Murmur. Ejection systolic murmur on the upper left sternal border with fixed splitting of second heart sound.
ASD.
Excellent.
ASD.
Okay, excellent. Murmur on the lower left sternal edge with sign of heart failure.
VSD.
Excellent. This is the question. Let's move ahead. Fine crepitation is due to left to right shunt, then into the lungs. That's why fine crepitations. Child complain of pain and swelling on one joint after 6 months, positive anti-neutrophil antibody. What is the urgent investigation you have to do? Tell me, guys.
Slit limb.
Why slit limb?
For uveitis, we will do slit lamp examination for GIA.
Yeah, uveitis is the right answer here. Okay.
For GIA.
Yeah, GIA. Juvenile idiopathic arthritis. GIA. Okay, because it is very dreadful complication, rupture could be there and blindness could be there. A newborn baby on individual examination had abnormal finding. Mother insisted to take the baby home on discharge. His mom is noted to have bruising around her eyes. Mom is noted to have a bruise around her eye. He is second sibling of 2-year-old who is found to be on child protection program. What will be your next step? Non-accidental injury it is. What do you think?
Contact midwife.
Yeah, absolutely right. So
child abuse.
yeah. You have to contact the midwife. Okay. There it is. Yeah. So you have to contact the midwife of safeguarding. Okay. You can't keep the baby with grandmother. Call police if it is immediate risk. After if safeguarding was not option, then you have call police. Okay. Police you have to call in case of high risk of suicide. One. Second, you have to call police. For example, if a boy and girl have a sex. For example, if boy age is a boy and girl age difference is more than 4 years. Just write it down. More than 4 years. For example, girl is 13 and boy is 18 at that time. Okay. Shall we move ahead?
Yes, sir.
Okay. 13-year-old girl transferred from primary to secondary school and then academically deteriorated. She is aggressive to friends. And at home, she is not obeying her parents. Counseling failed. What is management? First of all, tell me the diagnosis. Two differentials, tell me just. Or 3, you can tell me. It could be ADHD. It could be autistic. It could be oppositional defiant disorder. Have you heard about these? Oppositional defiant.
Yes, sir. Not following, not listening to the teachers at the school and not listening to the adults at the home, and going every time with the arguments with the adults. Yeah.
Yeah, absolutely correct. Well done. What's your name, doctor?
Position.
Yeah. Okay. So basically, if it is ADHD or autistic, everything, first of all, there is parent involvement, right? There is school involvement, school modification, patient behavior therapy, community participation. So best answer seem to be B, because if you go with A, patient behavior right, school modification right, community program right, sedative is not given. Why sedative? C, patient behavior therapy right, home tuition. Why you have to give home tuition? You have to make the school modification. Home tuition will make the child isolated. It will increase his symptom. Community program, right? Family education, right? Home tuition, no. Drug stimulant, no. First, we have to treat non-medically, then medically. Cognitive behavior therapy, right? School modification, right? Drugs, no. Clear? This is the way you have to rule out. Okay. 30. A mother known to have HIV on HERT therapy. HIV since 16 weeks of pregnancy. She's planned to have elective C-section. What is the drug to give intrapartum to decrease the risk of transmission? There is only one drug that we give to decrease the risk of transmission. Which it is? It is zidovudine. If in the exam the question comes, you have to write zidovudine. Now I will tell you. Just I am giving you a scenario, okay? Okay, just a scenario I am giving you. For example, I would say that HIV status of mother having a copy is less than 50 per ml. Are you listening? Less than 50 copies per ml. And what you will do? You will do elective C-section or SVD. Less than 50 copies per ml. You will do elective C-section or subcutaneous vaginal delivery. Tell me whether you will do SVD or elective C-section. Anyone?
SVD.
Elective C-section.
Yeah,
SVD.
absolutely. Elective C-section. Less than 50 copies per ml. Next question: let's feed a child or not? Less than 15 copies. You will not breastfeed a child. Okay, because less than 50. And the other thing is that you will give 3 drugs: zidovudine, triple therapy. Okay, so in short, if the question comes, you have to opt zidovudine, and it is the drug of choice that is basically used to decrease the risk of transmission to the baby. Just remember, okay? Just write it in your notes. 2-year-old, what is suspected speech and language? Now you guys will tell me what is the answer. Okay, tell me what are comparatives. Just I will say that horse is bigger than dog.
Maybe that happened when in 3 years.
3.5 year.
3.5.
What is negative? Negative mean horse and dog is there. He will say which one is not horse. For example, this is seen in negativity is seen in 3 year. What is adjective? Which of the following is red? It is seen in 3 year. So negative and adjective 3 year, comparatives 3.5 year. Understand 2-step command when it is seen. Two-step command is basically a preposition. It is seen in 2.5 year. And the last 50 plus words or 2 words together in 2 year. Got it?
Dr. Hamza, please repeat some
Okay.
adjectives.
Comparativities mean comparing something is 3. Negative mean which of the following is not horse, or which of the following is not house, or which of the following is not. It is 3. Adjective, which of the following is not red. 3. Understand 2-step command. It is preposition. It is 2.5 year. And 50 plus words or 2 words joined together is 2 year. I will share this developmental chart I have. You can see at that time. Okay, I will share in the group.
Thank you.
Next. 2-week newborn, his birth weight is 3.6 on breastfeeding as mother can't feed. Just remember, mother can't feed. Can't feed him. He has mild jaundice. His current weight is 3.2 kg. He has decreased urine output. What is your diagnosis? Tell me, guys. Hurry up. Tell me. Breast milk or hypernatremic dehydration?
It's a hypernatremic dehydration.
Excellent. Why?
Because mother is not feeding well, he has dehydration.
Absolutely. Absolutely. Look, hypernatremic dehydration, mother can't feed. In breast milk jaundice, yeah, it could be prolonged. It could be seen up to 12 weeks. It's right. But here you see, his urine output is decreasing. Mother can't feed. Okay. Breast milk jaundice and breastfeeding jaundice are different things. Breast milk is due to beta gluconidase. There is some enzyme, I can't remember this. I think so. That is due to this. If it was breastfeeding jaundice, then we could say that. Because breastfeeding is due to inappropriate feeding. That is basically result in hypernatremic dehydration. But breast milk is something. In breast milk, feeding is appropriate. Okay. So if in breast milk jaundice it is, then you will not get a decreased urine output. You know what I'm trying to say. So that's the matter. Next question is I think mother has in hypernatremic dehydration more you have. Yeah. Sorry.
Sir, repeat the breast milk. Just kindly repeat this topic.
Okay, sure. In breast milk jaundice and breastfeeding jaundice, breastfeeding jaundice can lead to hypernatremic dehydration because in breastfeeding, latch of the mother is not good. Okay, but in breast milk jaundice, there is an enzyme in the milk that could result in jaundice. So in breast milk, everything would be normal, like urine output would be normal, mother can feed, but there would be jaundice. And breast milk could be seen up to 3 months or 12 weeks. But in high breast feeding jaundice, because feeding is not appropriate, it could result in hypernatremic dehydration. Got it? Because of not enough milk to the baby. Okay. Moreover, in hypernatremic dehydration, you will get hyperreflexia, you will get hypertonia. You have to remember. Upper motor neuron signs would be there. Okay, guys. Next question is: mother has lymphoma and she doesn't like anyone to know. She has a conflict with his father. They had a child who has failure to thrive, and there is a meeting to discuss child condition. GP doctors very close to the family and know the past history. What is the role of GP in the meeting? Read growth chart. Why growth chart? He will have to read. Give information about the family. No, family. Give information about the child medical history. That is the right answer. Advocate for the parents. No. Give report about family accommodation. No. Family accommodation, occupation therapist. Advocate for the parents. It is also by. Sorry. It is also done by other agencies. Read growth chart. That could be done by nursing team. That could also be done by GP, but more appropriate here is child medical history. Okay. Got it, guys?
Yes, thank you.
Next, this patient was diagnosed with the diabetes mellitus, sugar level or control for the past 5 years. Okay. His father has a hypertension. What is the most important thing to tell to his family? Definitely, he will need insulin for life because it could be maturity onset diabetes of MOD. So insulin is needed for the life. You have to tell. That's it. Next question is: patient diagnosed with measles. After 10 days, 12 seizure tonic-clonic and received lorazepam, seizure stop, and drowsiness. Unresponsive fundoscope is normal, no focal abnormality. What you will do? Tell me, guys. What is basically
CT?
Why?
Encephalopathy.
Excellent. What is your name, doctor? Excellent.
Dr. Kuratulan.
Yeah, Dr. Kuratulan, you have done excellent. It's basically CT. Now I will open the
Sclerosing, ban encephalitis.
Yeah, basically measles result in encephalitis. Now I will open the guidelines. I will tell you. I will share everything in the group. Don't worry, guys. Look at this. First of all, always remember we have to check the airway breathing and circulation and blood sugar. Okay? Even in clinical, you can get meningitis and encephalitis case. If the examiner asks you, you have to say airway breathing circulation, then sugar, and then we will move ahead whether we have to perform lumbar puncture or not. Why we are not performing lumbar puncture? First step is airway breathing circulation, second step is blood sugar, third step is lumbar puncture, even in encephalitis. But why we are not performing lumbar puncture in that question? Anybody can tell, any intelligent person.
Child is not well, so we delay the.
That's okay, but here the child is having seizure. That's why we are not performing lumbar puncture. Whenever there is a generalized tonic-clonic seizure, or if patient GCS is less than hydrogenous is there, we don't perform.
Yes, this is I am saying.
So next step would be urgent CT scan.
Undergone this process.
Yeah. So basically, if GCS less than 12, if there is a generalized tonic-clonic seizure, right? If there is infection at the site of lumbar puncture. So first step is airway breathing, second blood sugar, third lumbar puncture. If lumbar puncture is not indicated, then you can go with a CT scan. And then you will move ahead. I will share this guide in the group. So can you repeat the step, guys? Guys, can you repeat the step? Hello.
First, we will go for ABC and then blood glucose, and then for lumbar puncture, there is a contraindication for lumbar puncture. Then we will go for CT scan.
Excellent. 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 Okay, guys, next question. Child known to have frequent viral associated with cough and wheeze. He is playing with pets at home. He is on PRN Ventolin. Shortness of breath, cough, fever. What is your advice? Here two answers are right. So what do you think? What it is?
Sir, child is having asthma already on Ventolin, so we have to add this next step, which is inhaled corticosteroid.
Actually, no, you're right, Dr. Gorath. The thing is basically what happened is that basically less than 5 year there is very difficult to diagnose asthma. We cannot label asthma less than 5 year, right? Because of P flow meter is not there. So we have to give inhaled corticosteroid. After if it is improving with 6 to 8 weeks, then we can label it as asthma. 1 point. Second is the skin allergy test, because we have to rule out other due to food, due to bee sting, or due to drugs. So skin allergy test is used for other triggering factors, right? Food, maybe due to some other reasons. Okay. Are you clear, guys?
Doctor, one thing, if in the question it's mentioned that he has cough only in the night, like he has only nighttime symptoms.
Yeah.
Then what is the answer? Inhale corticosteroids?
Yeah. Both are right now. Then inhale corticosteroid, because asthma usually happen in the night.
No, if there is a specify for the night time only.
Then inhaled corticosteroid.
Okay. Thank you.
Okay. Next is a 45-year-old child coming with a 2-day history of inhaled amoxicillin syrup for fever condition that develop intermittent screaming. Now you have to intermittent screaming, pulling his legs towards abdomen, pale. Between the attacks he developed vomiting for 6 times, and there was streak of blood. Last 2 times of vomit. What it is?
Interception, because between the episodes is absolutely well.
Absolutely correct. Intersusception, usually between 3 months to 2 years of age. Proximal Kolke pan with paler abdominal mass and recurrent jelly stool. Proximal mean one date would be there, other date would not be there, next date would be there, another date would not be there, and there would be red colored jelly stool, 3 months to 2 years. Remember the age. Shock is an important complication. We do rectal air insulfation. If it is unsuccessful, then we go for surgery. Okay. I will share this in the group. He will pull his legs up. This is also very important point. Okay.
Sir, in which group you are going to share all these things?
In that big group, FOP task. Okay.
Sir, WhatsApp group?
Yeah, WhatsApp. And as well in Telegram if you guys are there. Okay.
Okay, sir.
Okay. Next is a baby age 4 weeks, born preterm 35-week discharge at 2-week age. He came back after 2 week lethargy, poor feeding, and full anterior fontanelle. What is a common organism causing this condition? You guys will tell the answer of this.
E. coli, less than 3 months.
3 organisms.
Group B streptococcus.
GEL. Group B streptococcal, E. coli,
E. coli and Lisch.
But the most common one is group B streptococcal. Then E. coli come. E. coli is commonly seen in which metabolic condition?
Galactosemia.
Absolutely right. In AKP, metabolic is very hard. Very hard. MCQs are really torturing to the mind.
Sir, in illustrated book, it is written that if less than 3 months, then it's E. coli. If more than 3 months, in GPS.
But here 4 weeks, no?
Yes, sir. Then less than 3 months. So E. coli will be.
No, brother. Always remember gel. Okay. In neonate, this is neonatal period for 28 days. Okay. So 28 days, we have to remember group B streptococcal is the most. Then we will move ahead. Now here he is basically having this meningitis, probably due to group B. Then we go E. coli, and then we will move towards the Listeria. Got it?
Okay, sir.
In
Thank you.
Listeria, we will give a addition to another Genta. Okay? Gentamicin amoxicillin. Next question is scenario about tumor lysis syndrome, leukemia, low hemoglobin, high WBC, high potassium. Oncology team advised to start atopure. What you will give? Blood transfusion, IV saline.
IV saline, because hydration is the first step in tumor lysis syndrome.
Hyperhydration therapy. Because it will decrease the risk of renal failure. Moreover, in tumor lysis syndrome, you will get potassium high, everything would be high, only calcium would be low. Okay. Next is a 15-year-old boy, injury by needle at park, first refuses because he was scared, now attend. What to do? Avoid, give prophylaxis. Avoid, or you will give prophylaxis, refer to social community, give prophylaxis before, refer to IV team. I can't understand what question they are trying to ask. I think so this recall is not options are not very good. Normally what we do now in tetanus, we usually don't give booster vaccine if it is less than 10 years, and we have to look whether it is deep wound, if wound is dirty, like that. Okay. And here I think so we will give for prophylaxis because age is more than 10 years. Okay. And so better is C, give for avoid, give, mean they I think so they're asking avoid giving prophylaxis, give prophylaxis before. I think C is the right answer here. Okay. So you have to give if it is more than 10 years. Okay, guys.
Yes, sir.
Okay, next. Okay, most common cause of abstinence syndrome. Methadone or amphetamine?
Methadone.
Absolutely correct. Methadone is the commonest cause of abstinence syndrome. You have to remember. I will share the guidelines later. It is in neonatology. So methadone is the right answer. 14-year girl obese, limping. It is Parthis or Sufi?
Slipped upper femoral epiphysis.
Absolutely right. Because slipped upper femoral tend to after
SPFP is associated with obesity.
Obesity, it is associated
And
with hypertension.
Yes.
Excellent.
Parties will be in less than 10 years of age, and more than 10 years will be SCFE.
Let me show you Parthi's X-ray. It is basically sclerosis and fragment. You can see here, less than 10 years.
So, what is the answer? Parthi's?
Sufi, more than 10 years.
So,
Na? And
And
obesity is...
obesity is, yes, obesity is there, so we have to see the clue.
What is this, guys? Parthi's showing flattening with sclerosis and fragmentation of right femoral head. You can see. This is the Parthi's. If you don't understand anything, stop me there. I will explain 1000 times. Okay? Don't worry. Okay. Next is teenage mental disorder. What is the most common cause of suicide? Depression, eating disorder, alcohol intoxication, drug misuse. Tell me, guys.
Depression or drug misuse?
Depression.
It is written.
Depression.
It is written in AKP cases book. I think so. Which case? When I was preparing for the clinic, that the most common cause of suicide is if we have attempted previous suicide attempt. 1, male gender. 2, in female they usually have more suicide attempt, but they don't do complete suicide. 3rd is alcohol intoxication or drug intoxication. So C is the right answer. I will share that case of AKP. So alcohol intoxication, suicide attempt previously, and male or unemployed. Just write it down, guys. Hello.
Yes,
Yes,
sir.
sir.
Yes, sir.
Right.
Yes, sir. Thank you,
Male,
sir.
male child. Okay. Alcohol intoxication or drug intoxication. 2. 3rd is unemployed. Okay. And attempt to suicide. Just remember it. 22-month baby didn't receive any vaccine. What is the most important benefit of vaccine? This is a benefit of vaccine. Basically, they're trying to ask what is the most important factor maybe of vaccination. Decrease risk of complication, increase immunity, herd immunity, and prevent pandemic. What do you think, guys?
Herd immunity.
Absolutely right. Because herd immunity is basically, what is a definition? If you have vaccinated 95% of population, rest 5% would automatically get disease free. So this is herd immunity. Okay. And this will prevent the pandemic.
Whereas the child is taking no vaccine, then we are waiting for pandemic to be vaccinated. To get vaccinated.
Yeah, could be. So basically, 95% if vaccinated, so 5%, like now in COVID, if we say, if 95% of population has got this vaccination, so 5% who is not getting, they would automatically get vaccinated. Okay. Child with fever for 6 days, red tongue, eyes, cervical lymphadenopathy, swelling of hands, but will affect the outcome of complication. Which of the following dreadful complication would be prevented?
IVI.
Why?
It will prevent from aortic aneurysm.
Yeah. Basically, it is aortic aneurysm due to Kawasaki.
Yes.
Okay. Another drug you give, but intravenous immunoglobulin prevent aneurysm. Sign that indicate congenital heart disease. Murmur radiating to the back. Murmur in the lower left sternal edge. Both are right, I think so. No problem in that. Pulmonary stenosis and VST both are congenital heart defect. Okay. Patient come with chronic constipation, soiling. What is the symptom that suggests seek legal advice? Abdominal distension, past meconium within 24 hours from birth. Blood when rubbing with toilet paper. C is right, na? Because of straining, we have to. At that time, we have to refer. Maybe blood is. Why blood is there? Maybe there is some erosion of the intestine, or there is something. So blood when rubbing with the toilet paper, blood is there, so that's why we have to refer. Pain in the cough, hematuria, and fever. Viral myositis, UTI, HSP, glomerulonephritis. What do you think, guys?
Viral myositis.
Why? Why not glomerulonephritis?
Sir, it is glomerulonephritis because in viral
Cough
myositis
muscle
we don't
involved.
have hematuria.
And important thing is that, yeah, hematuria, that's very important. In viral, we will not get high grade temperature, 939. It's very high grade. In viral, you will get low grade. And it is glomerulonephritis. Why the pain in the cough muscle? What do you think, guys? Maybe due to electrolyte imbalance.
Acidosis.
Acidosis, electrolyte imbalance, renal shutdown is there, transient. That's why. So these are right answers.
And potassium is.
Yeah, potassium.
So what is the answer you select?
Yes.
D, glomerulus.
Patient came with substernal pain, systolic murmur, grade 1 at rest and mild exercise. He keen footballer, family history of ischemic heart disease, ECG normal. What tell the parent because they are worried? What you will do? Reinsure, echo, pH, 24-hour ECG, troponin.
It's an innocent murmur, maybe. So reassurance.
No, why reinsurance?
Sir, it's murmur, so we have to do echo. It's
yeah. Why you are doing reinsurance? A patient will die, doctor. It could be HCM murmur. It could be VST murmur. So whenever murmur is there, you have to look family history of ischemic heart disease. You will die if you don't do echo. Look, in innocent murmur, 5 S are there. One is normal S1, S2, symptomless, soft systolic murmur, not pan systolic murmur.
Okay. Thank you. Yeah, thanks.
Patient with a sickle cell anemia, what to give? Definitely prophylactic antibiotic. A patient diagnosed with GI, what to do? Urgent referral to ophthalmology because we have to rule out uveitis. Tall boys, secondary sexual characteristic not well developed, teased at school with mild learning difficulty. What do you think, guys? What it is?
Klinefelter syndrome.
Excellent. So 47 XXY. Next is a 13-year-old girl has a Down syndrome, weight loss of 5 kg, muscular atrophy, didn't start puberty, abandoned by mother when he was baby, tachycardia with 120 heart rate, agitated. What is the diagnosis? Simple, hypothyroidism is there. Look at the tachycardia, look at Down syndrome association, look at the weight loss, look at the muscular atrophy. Okay. Only distracted here is abandoned by mother. You will think as psychological deprivation, but you will not get the signs and symptoms of hyperthyroidism. 15-year-old.
Hypo and hyper could be occur.
Yeah, why not? Why not? Hypo, hyper, both are seen. Hypo is common, but hyper also seen. It's not like that you will get only hypo. Okay. 15-year-old after 20 paracetamol tablet intoxication, you told her to wait for 4 hours to do paracetamol level, but she escaped. You call her home and she parents state that she don't know where she is. What you will do? You will call the police or you will call child protection?
Call the police, she escaped.
Absolutely right. When she escaped from the hospital, you will call the police. Now I will tell you. Call the police in 3 cases. When age of the boy is more than 4 years.
4 years.
Other point is if there is there is basically like genital mutilation risk is there, right? Another is there if there is patient escaped from the hospital periphery. If it is in the hospital, then security, hospital security. Okay, got it?
Yes, sir.
Just write it down. You will have a patient with joint pain, macropopular rash, and there is no history of travel. So HSP. HSP has three things. One is joint involvement. Other is this rash, kidney involvement, and these are there in HSP. Okay, and renal involvement, rash on the buttocks, swelling could be there. It is HSP, macropopular rash. Patient
And
with
palpable purpura.
yeah, purpura is there, na?
Palpable
Because
purpuric rash.
yeah, it's vasculitis, na? That's why medium-sized vasculitis. Patient came with vomiting examination. His epic received metoclopramide and neck stiffness and rolled eyes. What it is? Ococylogrysis, Rolandic seizure, or myoclonic seizure?
Ococylogrysis, because it's
Absolutely.
a side effect of metoclopramide.
Because metoclopramide is dopamine receptor agonist or antagonist?
Agonist.
Yeah, absolutely correct. So we have is acylogyric crisis is the right answer. Extrapyramidal symptoms. What is antidote have here? What drug we will give? Procyclidine. Patient have JIA and after some time came with obesity, short stature. What you will do? It is Cushing syndrome. So basically due to steroid use in JIA. JIA, obesity, short stature. So you have to check cortisol level, dexamethasone suppression test as well. Because GI we use steroids. 8 years with history of father initially healthy, then developed stroke at 35, and uncle died prematurely 37. Mother was worried about the girl, asked about the advice. Lipid profile and discharge for follow-up. Now two options would be there. Lipid profile or you will do genetic testing. Tell me guys. What you will do?
Lipid profile.
Excellent. Why? Because familial hypercholesterolemia, you can check the lipid. Yeah. And moreover, until she is competent and she is willing to give consent, you don't go for genetic testing. Right? Next is what
they ask the initial step, then lipid, and if they ask definitive, it is genetic testing, I think.
But in 8 years, yeah, you're right. But in 8 years, we don't do genetic testing until she is competent.
In every disease, we have to look at if they are more than 16 years. Then we have to
look. In familial hypercholesterolemia, his father is died, so you will get the findings now. Then why you have to do genetic testing and give the pen to the child?
Okay, sir.
Okay. What indicate non-accidental injury? Bruises in the scalp, bruises in the back, in 5-month-old baby, bruises in the forehead, quadriplegic CP child with thigh bruises in 12 year. What do you think, guys? First of all, I will explain.
The back.
Look, bruises in the back in 5 months. First of all, it could be. But remember, a child could roll front to back or from front to back or back to front in 5 to 6 months. Point. Remember, in development, as I have read about the development, that in 5 months, 6 months, child can roll from front to back and back to front. So it could be accidental. Okay. Bruises in the forehead. Always remember T sign. T sign. You know T sign? Let me show you T sign. Can you see me? Can you see me, guys?
Yes, sir.
Yes.
This is T sign. Just look at it. This is T sign. This is T sign. This T sign is basically accidental injury. Okay. This is accident. Whenever you will get this accident. Okay. So this is basically due to accident. Okay. So here, bruise on the forehead 3 years is accidental, non-accidental. So only we are left with the quadriplegic child is totally paralyzed. He is wheel bound and he is having bruises in the thigh. It's made is non-accidental. Got it?
Yes, sir.
I need to explain again.
No, got it.
Neonate lethargy with high pitched cry. What drug abuse by mother is responsible? Always remember methadone. Just pet it. Abstinence neonatal abstinence syndrome is due to methadone. Last question is girl say mother hit with a stick. Doctor think girl is competent. Father is abroad. Doctor think girl is competent. Who will give the consent? Mother hit. Father has no contact. Mean he is abroad. Mother will give consent. Father will give. Doctor will give. Girl will give.
Girl is competent.
Girl is
Girl,
definitely.
because competent.
Because mother can't give because mother hit. Father is abroad. Father can't give. Only left with girl. So girl is competent. She will give. Okay, guys. So any other question you can ask me.
No, sir. But thank you so much. It was really needed, and you have done it really good. Thank you so very much.
Thank you so much, sir. It was
Yes,
really good.
Thank you.
thank you so much.
Most welcome. Most welcome. You have any queries, you can answer me in the group, and I will answer you. Okay. So thank you so much. My
Explain
session.
about methadone once again.
Actually, methadone is neonatal. In neonatal abstinence syndrome, you will get. You always remember the methadone is the main culprit. Okay, I will share the guideline there. So always whenever there is a neonate with a high pitched cry, or if there is a asking about neonatal abstinence syndrome, you will say methadone is the right answer. Okay.
Okay, thank you. Thank you so
Yes, sir. Thank you, sir. Thank you.
So much for attending, guys. See you. Bye.
We will discuss the next papers too or not?